Good afternoon. My name is Mike Mack, and I have the honor of moderating this session on the surgical treatment of atrial fibrillation. We're here at the Society for Cardiothoracic Surgery in Great Britain and Ireland in Birmingham in the UK. With me are three experts in the field, Mark Lemaire, Manuel Costella, and Niv Ad. Welcome, gentlemen.
Thank you.
So we would like to start with an overview of concomitant atrial fibrillation and the treatment of it surgically. Niv, could you kind of give us your overview of where we stand currently?
So I think that in the past 5 years we made significant progress in the US in the education of surgeons and incorporation of surgical ablation of any sort into the scheme of a concomitant procedure. That is to say, patients that are coming with significant history of atrial fibrillation to any cardiac surgery are getting some sorts of surgical ablation concomitantly with the index procedure, so to speak. There is an effort to improve the incorporation of the procedure mainly in areas where CABG is being performed and AVR is being performed. We didn't have much of a problem with mitral valve surgery, where the rate of surgical ablation was around 65 to 70% even 5 years ago, but we want to push it further. As for what procedure should be done, there is some controversy that I think mostly related to the fact that we don't have an organized education and training in atrial fibrillation. So it's more of an opinion, and it's hard to really defeat that because surgical ablation in general is not well supported by the industry, and therefore it's hard to create those surgical studies that may answer those questions. This is a nice surrogate to go back to your CTS-NET question and the results that are, if you just read the abstract of the paper or just look at the picture, it's kind of controversial, but I think the study is an important study, although the study didn't answer a question we didn't know about, which is if you do ablation, it's better for the patient whether or not, compared to when you don't do ablation. Where the study is somewhat misleading is in the lesion set comparison, which is way underpowered and was never designed to answer this question. And also, quite surprisingly, the study allows a different lesion set, especially when it comes to the right side, and different energy sources, that some of them are not considered to be transmural at all.
So let's get into that a little bit. Manuel, could I ask you, can you talk about specific management of patients undergoing various operations, coronary bypass, aortic stenosis, mitral surgery, paroxysmal versus long-standing persistent, different energy sources, and what you do? Could you give our listeners and viewers some guidance there?
Yeah, thank you, Mike. Well, one of the things that we, as you were saying, in Europe and in all over the world, very few patients are treated with the atrial fibrillation concomitant to their procedure that they go. You were saying about the aortics or the coronaries. Most of the surgeons, they don't do anything because they say, I'm not going to open the left atrium to perform full MACE to do these cases. We see the benefits of the MACE, and we need to convince all these surgeons to do the MACE in these cases, not only on the mitrals, as you were saying, that the mitrals is probably on the patients in which we do more MACEs. Yeah, excuse me?
So, a little bit what I see happening is from the CTSN trial, which looked at long-standing persistent at the time of mitral valve surgery, pulmonary vein isolation was just about as good as a full left and right-sided Cox maze. And now we see it, like you say, surgeons are reluctant to open the left atrium during a coronary bypass, so they just do pulmonary vein isolation.
Yeah, but in my view...
Is that a good thing or not?
In my view, it's a mistake.
Why?
I think it's a mistake because the paper was mixing energy sources and lesion sets. And when you mix two variables, you don't know which one is influencing the results. But we know by meta-analysis and by long series and by randomized trials that the full MACE is the best lesion set for patients with persistent or long-standing persistent AF, no matter if they are coronaries, aortics, or mitrals. So, and in this particular paper we are referring, they were using monopolar radiofrequencies for certain lines that we know that they don't do consistent lesion set, transmurality. So I would stick to a very simple idea, is that everyone that has a paroxysmal AF should undergo a pulmonary vein isolation and closure of the left appendage, and all the other patients, persistent and long-standing persistence, no matter if they are coronaries or valvulars, they should go into MACE. We can consider that patients that they are very sick because the left atrium is very big, or patients that they have, they are very old, very low ejection fraction, or very high risk for everything, that we can do nothing except of closing the appendage. So this is our strategy, and I think it's right.
So Mark, what is your strategy? Do you agree with that? And could you talk a little bit about the different energy sources and what you use for when?
Yes, thank you. Well, let me first comment on the trial, because I do believe that the trial is a major, let's say, improvement of the view we had about the treatment of atrial fibrillation. And why is that? We may not forget that for years, let's say, the society and the surgical community has been struggling with increasing the numbers of patients to be treated with atrial fibrillation in concomitant pathology. And I think the trial, although it is not, let's say, designed to do this, but at least it gives you, let's say, an opportunity to do less than a MACE procedure to these patients. And therefore, some of the surgeons who are now reluctant to perform a MACE procedure in let's say, in a certain number of their patients, because of expertise or because of, let's say, belief, perhaps they will now find, let's say, the opportunity to do something. And a PVI plus excluding the left atrial appendage is still better than doing nothing. That doesn't mean that I completely agree, but I think it opens the gate towards, let's say, more surgeons being able to treat arrhythmias. And that's what I think is the important message of this trial.
And how about energy sources? Radio frequency, cryo?
No, that's a very important question, because I do believe that the reason why it's so difficult to compare the current literature is not only because of difference in lesion sets, but because of the energy sources used. And we know that the bipolar, bidirectional radiofrequency energy is probably the best we can give. That doesn't mean it's 100% successful in all patients, but it's probably the best we can give. If you go for bipolar unidirectional radiofrequency devices, it is more difficult to get continuous transmural lesions. If you go for monopolar devices, we know that transmurality will be more difficult, and that doesn't mean that the device is not capable of giving you a transmural lesion, but the surgeon has to work harder to get that transmural lesion. So if he's just going around quickly with a pen, it will not work. He has to invest his time and his energy into the device. And of course we have cryo, and cryo is probably let's say the most reliable system on the non-beating heart. But there again, we know we have the standard 2 minutes in our head, but perhaps the 2 minutes are not sufficient in some of these patients. So perhaps it should be, let's say, give more time to the energy source to deliver the energy and to have better lesions.
So Manuel, you want to make a comment?
Yeah, you raised out the issue of education in a sense that maybe for many years we thought that this was the easiest thing to do, that the mitral repair was the difficult part of the operation, and that just putting a clamp here and there would make the procedure. But you're raising the issue of that. If surgeons have not done this never, probably the most easiest part is to do the pulmonary vein isolation. And then the other one gets a little bit more and more complicated. This is true, but we need to be able to show that to break the operation in the different steps to make it easy so everybody can do it. Because I think that we have a problem with this.
So Niv, when surgery fails, why does it fail? What are the most common reasons?
So we don't really know what is causing a failure in a given patient. We know what are the predictors for failures. And so the traditional predictor for failures are the type of AF, the duration of AF, size of left atrium, and the age of the patient at the time of surgery. However, we have an extensive database that is being collected, the data is being collected prospectively. And unlike others, the type of AF in our hands is not something that is a consistent predictor of failure. The most important one in our hands is the size of the left atrium and the duration of AF. This is why I want just to go back to Manuel's comment earlier about pulmonary vein isolation versus full mazing with paroxysmals. We just presented at the last STS a large series of left atrial only in concomitant. And what we saw is that what we found is that when you have zero risk factors for failure, success rate with pulmonary vein isolation only is about 91% at 2 years of medications. But if you allow 1 or 2 predictors for failures in the series, the success rate at 2 years drops to about 70%. So I think it is important to understand that we don't know why we fail in each given patient because we don't do an EP study to study it, but we know what are the predictors for failure. And going back to the devices we have are not perfect in a sense that we don't have a tissue response to what we do. We are ablating with warm or cold, assuming that the temperature of the tissue is minus 30 centigrade or 45 centigrade, and we assume that this is what the tissue is getting, but we don't have a feedback of the tissue, what's the current temperature. So we don't really know what we are ablating. So I think that that's another important variable that we need to work with the companies in getting those more devices and feedback while we are ablating.
So let me ask each of you, what is your technique for left atrial appendage exclusion? Mark, can we start with you?
So what I do is, let's say in nearly all patients, I would use a clip to exclude epicardially the appendage at the base. That's my technique.
Manuel?
I would use a clip also in patients in which I will do anything except of the left appendage, like coronaries or aortic valves that I'm not going to address the atrial fibrillation. In the other patients that I will do a full Cox maze, I will close from the inside with a double running switcher. And then in isolated AF, then we will say, but usually then a clip. Yeah.
Niv?
So I would say that in open cases, especially those with cabbage, I will excise the appendage because I have some concerns, especially for vein grafts to the OM system, that it will tangle with the clip. But other cases I will close with a clip on the open cases. With the minimally invasive, we used to close it in 2 layers from the inside, but we are not doing it anymore. We use the clip through the right mini thoracotomy across the transverse sinus, and we just published our first series, and it goes very well. So 80% of the cases probably clip, 20% probably excising.
So let's move on and talk about standalone atrial fibrillation and surgery for that. And Manuel, perhaps we can start with you. We know that catheter-based treatment of atrial fibrillation is exploding. What about surgery? Where do your patients come from? What patients are you treating, and what technique do you use?
Mm-hmm. Well, in here we have to differentiate very much between the paroxysmal and non-paroxysmal AF, that is persistent and long-standing persistent. Paroxysmal AF, it's going to be a cardiology catheter-based therapy. Even if you need to do 1 or 2 or 3 procedures. The results up to 5 years usually round at 70%. They probably are going to be inferior to surgery, but they are absolutely less aggressive. In persistent, in contrast, results with the catheter are not good. And then there's where surgeons can give a lot of help to these patients. And basically, if we join the electrophysiologist in what it's called the heart team for coronaries, because this is what our successful team can deal better with the patients. There are several techniques. What we are doing now is through port access, but we have done in the past through thoracoscopic from the right and the left. There are several energy platforms, and at this moment, they are basically all of them with the same results. So it's a matter of choosing the one that you prefer.
So Mark, which one do you prefer? What is your standard surgical procedure for standalone atrial fibrillation?
So we have a little bit different strategy. So we do let's say a hybrid single-step procedure. So we work in close collaboration with the electrophysiologist in the same day on the same procedure, which has an advantage, I believe, because now we can limit our procedure to a single-sided. We do a left-sided thoracoscopic 3 ports 5 millimeters approach, combined with a percutaneous approach from the EP. By having the EP in the operating room during the procedure or in the hybrid room, he comes, let's say, accustomed with your technique and with your capabilities. And that has changed a lot for us because we do get patients with paroxysmal atrial fibrillation. Half of our patients have paroxysmal atrial fibrillation, even first-time procedures, because they understand that, let's say, we are invasive, but once they see how invasive we are, they realize it is doable, certainly when you take care of the left atrial appendage, because endocardial closure of the left atrial appendage is not without risks either. So I believe that is a potential way to go. I do understand, and there have been many reflections about it, that it's not always feasible for a center based upon reimbursement, based upon logistics, availability to do that in a single-step procedure, but their sequential step procedure could give a solution. Always with the principle that the EP is always, let's say, collaborating with the cardiothoracic surgeon on the same patient. So for him, he's never giving away his patient. He's always involved in the treatment of that patient, and that gives him confidence.
So Niv, is surgery for standalone atrial fibrillation increasing, or is it just in isolated centers? And what do we need to do to increase the amount of surgery done for it?
Well, I think if you look at the STS database, it's increasing, but mainly at the arm that is utilizing beating heart surgery. So not so many are doing what we do, and we do very well. And I think this is an interesting time because, unfortunately, the definition of success of a certain procedure or certain treatment is utilized by the numbers of procedure performed and not necessarily about with the outcome. So basically we have to, I think, work harder in order to define what's the decision making and the algorithm. The facts are that we have no reliable device that can produce transmural lesion on a beating heart, especially in the non-pulmonary vein areas of the left and the right atrium. Even the bipolar clamp, if you look at the recent publication, even from Ellen Bogan, who is a very active electrophysiologist in the hybrid space, the bipolar clamp is deficient. So I think that realizing that we're penetrating to the field just to keep ourselves in the game, which is important, and increase the dialogue with the electrophysiologists in center that it's not existing, which is the key for any success, then we are accepting less than the gold standard. And there is an attrition in the respect of the gold standard across the globe, and especially in the US, but nobody can change the fact. If you know how to perform a minimally invasive MACE procedure on pump, using cryothermal energy, you have very, very low morbidity comparable to any catheter ablation. And success rate, it is outstanding with a single intervention. The problem is that it's really a hard sell. And I think we see it now with the aortic valves. I mean, if you can avoid surgery and do TAVI, I mean, it doesn't matter that you have, all those downsides of TAVI that are not many, but there are some. Then that's what we see. People, patients, cardiologists, they prefer not to have a full-blown surgery on their patients.
Sure.
So I think it's an interesting time. So surgery is increasing, but we have to be very, very careful not to compromise on the results too much. Then they will come back to us and say, "Whoa, look at that! The results are terrible." One great example is a paper that was just published by Natale in the Journal of Clinical Electrophysiology, showing horrendous results of the convergence study or convergence device with end contact inferior to catheter ablation, both in success rate and in complications. So we have to be very, very careful.
So unfortunately, we're out of time. I think we have barely scratched the surface here and we could go for another hour, but they won't let us because nobody will watch if we continue on. So I would like to thank the three of you for an absolutely superb session. It's been very educational for me, and I trust that our viewers will find it very educational for them also. So thank you for joining us today. We're at the Society for Cardiothoracic Surgery in Great Britain and Ireland in Birmingham in the UK. It's a great meeting, and thank you all for the great session.
Thanks to you.
Thanks.
Okay.